Hi, and welcome to the BIPOC Perioperative Leaders to Know 2021 edition. My name is Josiah Whitman, and I'm the CEO of Whitman Partners. Today's guest is Cherie Allen. Cherie, in a moment, I'm going to jump into the questions and we'll have 30-minute discussion. But to begin, will you introduce yourself?
Hello, my name is Cherie Allen. I'm a BSN registered nurse, and currently I do consulting and interim positions for surgical services managers and director positions.
Terrific, terrific. Cherie, can we start here? Can you tell me a little bit about what drew you into the medical field to begin?
I think it was what brought me to the medical field was my grandfather. And my grandfather was my babysitter, and he said, "Hey, I have to go to work." So my godfather was a physician. So he would drop me off at his office, and I was young, and I was like, "Oh, this was interesting." And I've always been interested in something medical, even throughout my high school career. And then when I graduated, I went to medical assistant and I became a flight attendant. And as a first flight attendant, most of the things you're doing are first aid. And I was like, I should be getting paid for doing this. So when I found out they were going to do a early buyout for flight attendants, I went back to school to become a nurse. And so after I graduated as a nurse for 6 months, I was a flight attendant and a nurse, and figured out that I couldn't do both, that it was too taxing on me. So I resigned as a flight attendant. And that, I've always had love for medical. And then when I started nursing, my first love is surgical services.
Interesting. And so it's your second career. And then you
Yes, sir.
rapidly moved up into the director role. And tell me a little bit, and then from there moved into the interim director role. Tell me a little bit more about that. How long did it take you to go from staff RN and into the leadership roles?
Um, Pretty quickly. I started off after graduating from nurse as a physician nurse extender, which means I had to sign up for medical staff privileges, and I assisted the plastic surgeon in the Department of Surgery. And so we worked together for 3 years. We had a good routine, and he thought it was best for me if I learned other avenues in surgical services. So if I had an off day, I would go and learn circulating. Um, and then I went to a hospital to do part-time circulating on the side. And they were offering me according to my credentials, and said they couldn't pay me that price just to be a staff nurse. So they created a position, a coordinator of surgical services. And from there, they say, build it, make us happy. I believe I did a great job because that director gave my name to another director who needed assistance. And then that's when I started my interim and consulting. We went from, I think, 20 to 25% to 90% and on time starts in 1 month. So, as directors, they talk, they get together, and she's like, "Oh, I need help. You think she can help me?" And that started my interim and consulting.
Interesting. Okay, can you remember what actions you took to move the needle from 25 to 90%? That's quite impressive growth.
What I did was I made sure that the staff that were there because they had an evening shift, made sure all the cases were pulled. And then I encouraged a tech with pay that if you came in every morning an hour before any, so she would get there at 5:30 and push all the equipment and all the supplies in the room. So the only thing that had to happen, they had first assistants, was a tech and the first assistant open. The circulator checked the medicines and the patients and the chart. And then when anesthesia got there and the doctor got there, they should be ready to go. My time frame was all circulators are out in pre-op 10 minutes before surgery started so they can go back on time. And that worked. And many circulators and leaders know that getting anesthesia and CRNAs to move and doctors there on time, that was a significant challenge. But once we started with the staff and they saw the staff getting there and ready when they got there, then they stepped their game up also.
That is it, very good, Cherie. That's a nice story. Thank you for that. Okay, great. And so let's turn our attention to you as a member of the BIPOC community. Have you ever experienced or witnessed discrimination in the medical profession? If so, how was it handled? How did it impact you professionally and personally?
Well, I've seen it in different roles. I've seen it as far as in patient care, and I've seen it on peer to peer. I think, as I'll start with peer to peer, that it goes with maybe them not even knowing what they're saying or what they're doing is a little, racist. So I think asking and listening to them and saying, hey, did you know that and that and that? And there's like, oh, wow, no one ever told me that or ever said that. So I think it's first finding out what they know or if they even knew that they were saying anything wrong. As far as patients, we can't group patients out. Oh, they're all surgery patients. Each, you have different cultures, have different things that they will and they will not do, as far as anything. So as far as, say, African Americans, they're going to come in with their hair pulled back with a lot of bobby pins. So it's not exactly racial if they say, hey, do you got any pins in your hair? Because that is a concern for surgery. And it's just teaching the staff that it's the way that you ask and the way that you handle it. And some people may be sensible, but sometimes you have to take a step back, take a breather, and listen. And then to address it immediately, not during the case, but to address it immediately, because sometimes people forget what they say and they may not remember that they've done something that was not appropriate. I can say my last instance was in Minneapolis, St. Paul. I won't say the hospital. But they were posting Confederate flags, and they have these I have bears, little bears that have flags, and you have a set of them. And someone put a setup in the window with the Confederate flags, and someone threw them in the garbage. Then the person that put them up said, hey, I put them up because I want to sell them. Now, I got the call that weekend when it happened. So I'm waiting because I'm consulting with the director and the manager, and I'm waiting for them to see what they're going to say. Now, the director responded immediately, what do we do? And I say, well, get all sides of the story first, call, HR, and then you might have to have some diversity training and some education, because clearly, I said, well, do you think that person didn't know that Confederate flags were offensive? And she's like, there's no way he didn't know that, because they had a conversation before, because they were going through the George Floyd trial. And at that time, it was very hot topic. We don't talk about sex, politics, or religion, is how I was taught, in the surgical services. So when they spoke with him, HR came back with wanting to penalize the person that threw them away in the garbage for damaging property instead of trying to address the person that did it. And it caused a big distension throughout surgical services. And so I just politely stepped in and say, how about we do this? How about we just take a break, take a week break, rescind punishing the person that threw it away, because if she goes out and she tells everybody and then they have a union, then you're really going to have a big issue. And just talk to everybody first before you do that, because if you do that, no one's ever going to speak up again, and they're just going to sit there and seethe in being angry about things that are done. So they talked to him, they took it down, and then HR was going to come in and do a series of classes and lunch and learns with the staff, and they decided to do it with the whole hospital.
So, okay, if I understood this right, you're in Minnesota.
Yes, sir.
During the George Floyd trial, or I mean, it took a long time. During the George Floyd trial, and someone puts Confederate flag paraphernalia, ostensibly for sale, up in the hospital sort of bulletin board.
The staff lounge where all the people go to eat, not surgeons, but staff, you know, FAs, techs, CRNAs. Yeah, someone put it up.
Wow. What a unique
And,
experience.
I was shocked because you knew there was tension because in every corner there was National Guards with guns. I'd never been in a situation like that. So I was concerned. I didn't feel anything towards me when I went to the facility, but you could tell there was some type of tension there. And I spoke with the director, and the director took a little bit ownership of it. And the ownership she took was that her first week there, she was doing some education on the towers and the ancillary sleeves and the ancillary monitors. And she said where she came from, they called the monitor slaves. So during the meeting, she told one of the techs to go get the slave. And that started it all. And I think that's one of the reasons why they brought me in to kind of offset to see, say we're not racist and stuff like that. But that started it all. And then they had an uproar about that. And and then after that was the bears and the flag.
Right. Okay. And they brought you in because you're Black also.
I think so, but I would not really say that. But I think they did not have any diversity in their leadership.
Right.
So as a consultant, they brought me in to help them get ready for Joint Commission. Now, Joint Commission backed out of coming because of the tension at that time. So they said they didn't want to come during that time. And I think that the tension just escalated as the trial went on. You had people on both sides, and it was just, and it was after the insurrection also, and it was just too much going on in the world for that to even happen. I don't know how they could have prevented it other than saying, hey, you can't post or sell anything in the lounge. I think the gentleman had a not a good spirit about him to do that, because you had to have known what that symbol was for. And when I spoke with HR, interviewed me, and we were trying to come up with, and I just asked, I said, do you think he knew that something was wrong, or that? And they said, oh yeah, he knew what he was doing was wrong. So I left it like that, because sometimes people just don't know. And these days you would think people, but if no one ever told you, like, hey, Cherie, you got a big old bird on your head, and I'm talking, they never tell me, and I don't know. So I think that a lot of times, you just have to come straight with people and tell them, hey, that's not appropriate.
Right.
And, and you can't offend them where it might be appropriate in their upbringing and stuff, but in the public and in a environment where you have different diversities, that was not acceptable.
I see. Are you concerned about the lack of diversity in the operating room? And if so, do you have any ideas of how we can address the problem?
I wouldn't say I have a big concern. I will say there is a concern about diversity in the OR. And as I travel across the United States and I go to different areas, sometimes I'm the first African American that they've ever seen in the hospital. And sometimes I'm the first African American that has ever come into their OR. They do not have diversity. And my concern is that if you don't treat patients of color and different ethnicities, then you're never going to know that there's a difference. I say everybody gets safe, patient, caring care. That is it doesn't make a difference what color and what ethnicity you are, but sometimes you have to adjust what you say and how you say it sometimes with different ethnicities. And if you don't have diversity in the OR, that's who you can educate, but you don't have someone that can support the education if you don't have anybody in the OR. And I can say, as far as leadership, there is very, very small, minute leadership. I'm going to say directors in surgical services, period.
Right. So if I heard you right, you can say it's one thing to educate on the topic, but then you need to implement. And if you're going to implement, you need to have diversity in the operating room, because what's the point of sort of educating and then just sort of letting that class just fade away as the memory fades, right? So
Yes. And I know as far as continuing education and hospital employment, that you have to go through some, yearly education, hospital education. And all you have to do is, a lot of times, all you have to just do is say, I agree. You don't even have to read it. So, and you have so many that are due at one time. A lot of people just check the boxes and say, I understand, but not even actually realize what they're understanding,
great,
what they're
great,
signing. Uh,
great, great. What
I'm
advice?
very educational. If someone asks me, I can say, well, in my upbringing, that would have been inappropriate. But whereas in your upbringing, that was acceptable. And that's okay if you have that balance. What's not okay is trying to push your ideas and your upbringing on someone else. It's okay to have differences.
Right. Okay, good. What advice do you have for the aspiring BIPOC perioperative leader?
Um, Stay steadfast that it will get better. It is getting better. And it's going to be up to the leaders and managers, I think, at looking more so at in areas and colleges that have a more diverse to pick from. The pool is getting bigger. So, you have to make yourself open to going outside of just the local pool. Um, and look outside the box. So when I go in, I don't look at diversity, but it is right there in your face when you walk in and you're sitting in the office and people keep walking past the office and they're not stopping. And so I stepped out and I asked someone, I said, hey, what's going on? And they said they had never seen an African American nurse before. And I said, are you serious? So every time they walked past, I was like, hi, come on in, so you welcome them in. But I think that the people that hire are going to have to look. And, hiring is it's tough right now in surgical services, in any part of the hospital. So I think you have a bigger pool to look from. I do know that when I graduated, I said, hey, I want to go work in surgery, because that was where I did my rotation. And I was told that you have to have experience. I said, well, how do I get experience if you don't let me to get in experience? So now I know a lot of hospitals are doing perioperative one-on-one. So you don't have to have experience now. You could be trained. So I think who has it the best would be the union hospitals, because if you apply for the position and you have the seniority, you get it. So it's not on, race or who meets the qualifications, although I do think that they should have some med surg experience if they're raw. But I would be putting myself back out there if I said that, if no one gave me a chance. And my chance came from the Department of Surgery, Plastic Surgery, who said, well, we'll train you and we'll educate you and we'll send you to the classes. And they did that. And they also encouraged me to grow.
Right, right. Okay. What is the best way for healthcare providers to handle vaccine hesitancy in the Black community?
I think that it would be education. I know I hear a lot out there, and they're still referring to something, the Tuskegee experiment and stuff like that, and they're not trusting the government and everything. And I think where it's going to happen is going to have to happen in the churches. It's going to have to happen in the community. I know that we were that we experienced death more so, and as far as African Americans, but it's not because we weren't getting the vaccine, it's because our comorbidities. So you have to address the comorbidities. It has to come from, like if someone's talking to me, if your doctor's African American, I do classes, and I had at my church, I'm the healthcare coordinator. So we had a Zoom meeting and we invited all the leadership from the church. And so I spelled it out to them. I gave it to them scientifically. I gave it to them ethically. And then I said, but ultimately it is your choice and your decision, but you can't come back and blame, the other side when you did not get vaccinated and you had that information. And I think sometimes bad things had happened in the past, but we're now in the future. And what is going to be the future for you and your family? And I just take a hard line when someone asks me, if it's someone I can take a hard line with, I take a hard line. And at church, they know Shree's going to shoot, and she's gonna give it to us straight, and then we can take it or leave it. And I still get calls, and I'll be doing another seminar for our church. I've also encouraged churches to have the vaccine dispensed there. If you have a big church, you can do it in the parking lot, set up a team that would come in. So Meharry did that. Meharry Medical College did that for our churches. And they were going around in the community in Nashville at churches giving the vaccine. Then you had the senior pastors doing infomercials and everything just to get people. But I'm just going to say that although I'm in Nashville and that's the South, I was not raised in the South, that the South is a little bit more, what would be the word? They're a little bit more unbelievers than up in North. And so, and that's understandable because of things they went through in the South. Wasn't privy and I did not experience that, but I still say you got to you can remember what happened and keep that in the back of your mind. But sometimes, as we progress medically, you have to progress also.
Right. Great advice about the church. And the position that you took was healthcare coordinator. Was that the word?
Yes, I am the Temple Church in Nashville, Tennessee's healthcare ministry coordinator.
Healthcare ministry coordinator. So
yes, so I do all first aid. I have to do 3 events a year, and during the pandemic, we did Zoom meetings. I partner with the pastor's wife. We do breast cancer, we do diabetes, we do HIV/AIDS, and I'm responsible for the first aid during church services. When we were in service, I was responsible for maintaining all the equipment, and if another say ministry wanted to have something that dealt with anything medical, it had to come past me first to make sure that we were that, because our liability insurance, some things you can do, some things you can't. Disposal of waste, if it was urine samples. So I make sure all that is up to par.
Great. That's terrific. Okay, Sheree, what is your favorite or a current book that you are that's on your nightstand related to your leadership or the BIPOC experience?
Well, I'm going to say I do a lot of reading at work, so I don't do a lot of reading at home, but I do have my own ARN perioperative standard book at home. So at night, if I during the day, if there's something that came up, if I don't know, I say, hey, I'm going to research it and I'll get back with you tomorrow. So I'll go and look through that book. And so that is the book that actually is sitting on the side of my bed. I watch TV more so than I do read. And I know that's a shame, but that helps me, because when you get staff and they're asking you a question, you got to come up, if you have any credibility, you're going to say, well, let me research that to make sure I'm telling you what's right, and then come back tell them where you found it. And, so that's my favorite book on my nightstand.
It's not a shame to watch TV if the book on your nightstand is the Association of Perioperative Standards, right? So
Yes.
yeah.
Well, when you're in the field, that is actually your Bible, when you're in the field, because, not only are you consulting and, director or manager, you are also an educator. Most surgical services don't have educators now. So you're also the educator, you're the updater, you're the one trying to get them to go to ARRN. And so I think that if I have the knowledge and you have the knowledge, then we pass that knowledge on to someone else, then that makes for better safety in the OR. And, and I don't want to be the only one with the knowledge.
Right. Sheree, this was terrific. I really appreciate the fact that you were so confident in your opinions and had such great ideas. The church idea I thought was terrific. Your story about being an interim director in Minnesota during George Floyd, very compelling. And then of course, first case on time start. How valuable would that be? So that wraps up today's talk with Sheree Allen, part of our 2021 BIPOC Perioperative Leaders to Know. Thank you, Sheree. And
you're welcome.
Yeah, keep up the great work. Thank you.
Thank you.